wonderful turnout, and we know we're going to have a wonderful hour together. My name is Cynthia McCurran, and I'm the Dean of the Kirkhoff College of Nursing here at Grand Valley State University. And it's my pleasure to just give some opening comments. We have just spent a bit of an hour with our interprofessional colleagues, including our guest and Bonnie Wisorik. And in that time, we really reminded ourselves again of the enormous amount of work that needs to be done in healthcare in the United States to address the many challenges that we have, to think about the truly transformational work that we need to do and the redesign. And so as you sit here for this next hour, I want you to be very contemplative and intentional about what you're hearing. And remember, despite the fact that it's extremely overwhelming, the work that needs to be done, it happens because each of us truly believes the work needs to happen, and we're very intentional about that work. And I want to remind you of a famous quote from Margaret Mead. Never doubt that a small group of thoughtful, committed individuals can change the world. Indeed, it is the only thing that ever has. So keep that in your mind as you listen, and let me first begin by telling you a bit about Bonnie Wisorik. It's a very special honor for me to be able to introduce her. Joining with Grand Valley and the College of Nursing, we launched a campaign for the Bonnie Wisorik Center for Healthcare Transformation in 2009. This center became fully endowed in the summer of 2014. We are now deeply entrenched with opportunities to advance her legacy and her work, and her vision for interprofessional collaboration and practice. What is the legacy work of this amazing professional colleague? Her professional career has evolved from staff nurse here in Grand Rapids at Butterworth Hospital to being an instructor for that same hospital school of nursing, to positions with Grand Valley State and the Kirkhoff College of Nursing as a clinical faculty and research associate. The seed for her passion for the synthesis of knowledge and practice was planted at this point and has flourished ever since. Bonnie Wisorik is the founder and chairman emeritus of the Clinical Practice Model Resource Center and founder of an international consortium. Her mission is to co-create and sustain the best places to practice and the best places to receive care. Over the last 2 decades, she has partnered with thousands of interdisciplinary practitioners from rural, community, and academic university settings, working to create healthy, healing practice cultures and patient-centered, integrated healthcare systems. Her leadership in the development and implementation of an interdisciplinary professional practice framework with evidence-based tools and resources has literally revolutionized practice and automation. She has shared her expertise and learned from the expertise of others from over 1,000 diverse clinical settings and professional organizations, both within and beyond the healthcare arena. She is internationally known speaker, a storyteller, author, and healthcare futurist who has written many books, articles, videos, CDs, and DVDs. It has been said that Bonnie connects with the hearts and minds of others and brings a sense of direction and hope in the midst of chaos in today's healthcare arena. And this is the connection that Bonnie has brought to us. It is apparent why the Wisorik Center strives to honor and sustain the legacy of Bonnie Wisorik. Her professional and her personal journey in life provides the consummate model of a legacy leader. Her work was always targeted for the point where the hands of those that give and receive care meet, and was driven by the need for transformation in the workplace culture. Her work is known for what it has achieved for others. As students, faculty, and community partners join in the work of the center, we anticipate that future legacy leaders will be developed. The attribute of legacy leaders will surely advance the Institute of Medicine's desired competencies among all healthcare professionals. To lead as a legacy leader takes courage. The center that we have grown now is where the collective wisdom and support exists that can develop that courage. So please join me in welcoming Bonnie Wasori, who will introduce our distinguished speaker.
Good morning. It is really humbling to be introduced like that, so don't get your hopes up. What a privilege it is for me to introduce to you our speaker today. And I just wanted to show you something. Now, you can see from here what his positions are, right? You can see that Dr. Viggiano, as a physician, he decided 40 years ago to enter into med school and in internal medicine, and then made his decision to really focus to those people and became a gastroenterologist. And you can see that somewhere along the line, he decided he needed to go back and learn more and got his master's in education in addition to his MD. You can just see from his position as a professor at Mayo, a place we all know, a place we all really cherish for the contributions they have made in healthcare over the years. And many of you probably have had family who have gone there as I. And he's a leader there. And he went back to school to learn about education. That tells you a great deal about him. Now, if you really wanted to, I could read you, it's 55 pages long. But I want to tell you that I think what matters this morning is that we had the privilege to meet, and I got the chance to know who he is. And the greatest honor we could give him is to listen closely to what he has learned over the last 40 years as a profound leader in his medical profession, as obviously, since he's been Teacher of the Year many times in his history here, that students recognized that there was a wisdom in him, and they so appreciated, they honored him in that way. He's been honored by speaking to thousands of people across our country and different parts of the world. And you might say, what is it that they came to listen to? And I think the greatest honor we could give him now is to have him fill the rest of this time as an unbelievable leader in healthcare transformation. So, Dr.
Make sure the microphone's on. Well, Bonnie, thank you, and Cynthia, thank you, Evelyn, and Kelly, thank you very much. It's an honor to be here. This morning we're going to talk about something very important, but I think I'd like to pay tribute to Bonnie on a personal level. This model that she created, the CPM framework, it has been a very durable model. It's complex, but it reflects the complexity of healthcare. It is a wonderful model, a conceptual framework for us to think about the work that we do and the work that we need to do. And it has so many elements in it that we're going to touch on in today's talk that are important, like having the patient at the center of everything that we do, understanding the role that culture and beliefs play in this, and how we're really all in this together. So Bonnie, it's a privilege to be here to pay tribute to you. Your life and your work has made a difference, and thank you. So with that, it's wonderful to see so many students in the audience, because I'd like to begin by really thinking, I want you to imagine that your cell phone just goes off now. And somebody that you love dearly is in an accident. And what you know is that they're being rushed to an emergency. And you know that it's potentially serious. What is it that you would like healthcare providers that they meet? What would you like them to be? What are your concerns about that situation that your loved one is entering? Any volunteers? Anybody want to mention something that they would like? Just shout.
Competency.
Pardon me?
Together as a team.
Do they work together as a team? Very good. What else? Anything else?
Competency.
Competent. Do they know what they're doing?
Compassion.
Compassion.
Not wanting to know this person.
If they're in mobile Alabama, and you'd like to know that person, you said?
Yes.
But if you're not in your own community, what if you're in a,
If you're way or similar that person could be noticed, but you don't have to start from square one.
right, that it's an emergency setting, and your loved one may have to take whoever's on duty. And what is it that we would want? So really, you hit all the points. You want to know that they are an excellent professional, that they're competent, that they know what they're doing. You want to make sure that their value system makes sure that they place the welfare of your loved one above every other consideration that could come. And one that just recently has really entered our radar screen is that you want to know whether or not all the people that they're meeting can work as a team. And that's relatively new. So why is it that we would even worry about that? Why isn't it that it would be automatic that we would think that, gee, they're going to get to conflict? Because we know that that isn't the case. We know from the report from 2001 from the Institute of Medicine that the gap between the average care that a person gets in our country and the highest level of care that's possible is a large, large gap. Senator Tom Daschle was the Senate leader at the time that this report was delivered. His quote was that we have a few islands of excellence in a sea of mediocrity. So how can this be? All your training, all your education is about competency. You want to make sure that you know what you're doing. And competency are behavioral demonstrations of integrated sets of knowledge, skills, attitudes that define work in a specific profession applied in a specific care context. We want you to know what you're doing as an emergency room nurse, as a pharmacist in a hospital, as a physician. And part of where this all came from is, what is it to be a professional? What does it mean from society's perspective? Well, it means that we do possess a specialized body of knowledge. We're expected to practice that within an ethical framework. We meet a societal need, and in return, society grants us a fair amount of autonomy in how we do it. That we have the discretionary latitude to say, what are the requirements for becoming a physician, a nurse, a social worker? And we ensure our own professional standards. And that's wonderful, but if we examine this carefully, profession is from the Latin professio, and it means to declare aloud. It means to proclaim something publicly with the force of a promise. And so when people go to an emergency room and they don't know who's there, they place their faith in us, they're expecting that we are competent and that we are professional, that we will put their welfare first. And what we're going to talk about today is how this graduated from being about individual competency to being about team competency. And what happened is that along the way, when all these oaths, I took the Hippocratic Oath, and I say it every year at graduation. And it was meant, when I took that, my concept was that I was promising what I would do one-on-one with an individual patient. And there were some societal things, but really if you look at it, it was about me being one-on-one with the patient. And healthcare has changed enormously from the time when doctors made house calls. Now it's highly technical. There's many moving parts, and it involves other people. And what happened is that new arrangements were required, which promoted the social process of communicating, cooperating, coordinating, and integrating for the purpose of us exchanging our ideas, our expertise, our theories, and our perspectives. But if you were to look at how we're doing, the most common reason there's such a big gap in average care and excellent care is that we don't coordinate our work well. And it's not that anybody intends for this to happen. It's that this is complex, it's fast-moving, there's a lot of moving parts, and we're human beings, and there's opportunity for things to misfire. So what is it that we could do? Well, the first thing is to realize that once we understand that I could not meet any patient's need without the help of the other professionals that I work with, that confers upon me a moral obligation. I have to be able to work well with others. It is a team sport. And we work together to alleviate hardship and suffering in the individuals, the communities, and in the societies in which we live and work. And so I mentioned the Hippocratic Oath for physicians, and an oath is an act of profession. It's an act of publicly declaring with the force of a promise that we will do good things. Another act of profession is every time we take care of a person. Our daily work is an act of profession. It's where we together proclaim to them that we are competent, that we are professional and will place their welfare first, and that we work together as a team. And so if we look at that, another way of framing this is that this is a collective covenant that we establish with patients. It's based on trust. They place their trust in us for their health, for their lives in some situations. And it requires all of us to show up. We can't do this without everyone being on board. It's a shared responsibility, a shared covenant that we have with society. And so in recent years, there's been discussion about what are the competencies that one would need for interprofessionalism, to be able to work together across the professions with other healthcare workers, with patients, families, communities, and populations. And what's the purpose? What's the goal of our working together? It's to improve outcomes for patients, for populations. It's to achieve the highest possible standard of care. That's our goal. And so the concept of what an interprofessional team has come up, and an interprofessional team is made of many different professions. They have their specialized bodies of knowledge and skills, but they integrate their work, they coordinate, they communicate, they collaborate, they work together. And in fact, we have definitions now for what it is for interprofessional collaborative practice, because that's the goal that we have, is to practice together. And this occurs when multiple healthcare workers from different professional backgrounds work together, so you can see the common themes. It's very easy to understand what it is that we need to do. But why isn't it easy to do? Why do we have to talk about it so much? Why is there so much more to do? And it's not an easy answer, but there's a lot of differences that we have historically and in the cultures of our professions. There's rivalries between some professions. We have differences in language and jargon, and we spent a little bit of time talking about how we think we're communicating about the same thing, and yet we're using the same words and we have an entirely different construct in our mind, what we're talking about. And we do have different routines in the way we approach things, varying levels of preparation and qualifications. But the biggest thing of all is that when we come together as a group of professions, We have a fear of diluting our own professional identity. Conflicts over authority, power, control, and what Irvine called jurisdiction, other people call scope of practice. It can be a good thing if we define that way. It can be a bad thing if it becomes territorial. You're not going to let that nurse tell you what to do, are you? Well, yeah. This is the barrier. It's whenever we see that there can be conflicts as we work together about who should do what, particularly when those conflicts cause us to defend certain things because we think they are strategic to the identity of our profession. And these are real barriers. So how can we get through this? Well, it's only going to get more difficult with time. The students sitting in the audience, and I can tell you, you're entering the greatest work that you could possibly choose to do. It's wonderful. You're going to love it. And you're going to be challenged by it. And that's good. Healthcare is going to become more complex. There's going to be more pressures to control costs. Technology and knowledge is going to advance. It can all be very, very good. But we need to learn how to work together. And one thing that now has finally risen to a more robust conversation is the way we educate healthcare professionals. Why is it that, how can we expect them to work together if they learn in silos, if they never learn together or learn how to work together? And so in recent years, the concept of interprofessional education has taken really a very active dialogue in recent years. And what's the goal of it? Well, it's not about learning together. It's about being ready to practice together. It's a collaborative, practice-ready workforce. When you graduate from school, you should know how to work with other professionals. And really, what is the goal for all of our professions? I would submit it's the Institute for Healthcare Improvement's AAA. That we have to improve individual patients' experience of getting care. We have to improve the health of the populations where we live and serve, and we have to reduce the cost of care. And that doesn't mean just containing services. It means making sure that we make high-value decisions, that people that need a lot of resources get them, regardless of things like insurance, and that we don't waste money by over-providing or over-testing, and we have to get better at making responsible decisions. And so, if you were to look at the definition of interprofessional education, it's very easy. All you need is 2 or more professions to learn about, from, or with each other. Gee, that seems easy. What's up with that, huh? So what are the best strategies? What do we know about it? And the answer is we don't know much about it. Because a lot of times we're comparing apples and oranges. Another thing that we do is we talk about, this is what worked. But we don't talk about why it worked, in what setting, for whom it worked, and why it didn't work in another setting. And what is it that we can learn about the contexts in which we make our reports. And so we're really starting to explore what interprofessional education is, and this is the most recent analysis, and the answer is that we really don't have good evidence to tell you what it is that works. And so I thought that it would be nice to try to sketch out some ideas about what it is that we need to do or how we might succeed at this. So years ago, a group of professions, nursing, medicine, pharmacy, public health, dentistry, came together and said, what is it that people need to learn in order to be collaborative practitioners? And that was called the Interprofessional Education Collaboration. And there were 4 domains in which this group, I had the privilege of serving on this group for the Association of American Medical Colleges. And it came down to values or ethics, roles and responsibilities, communication, teamwork. This is like soft stuff. Right? When I was in medical school, we didn't talk about this stuff. It was too important to talk about biochemistry. And I've never used biochemistry ever since I graduated. So this isn't the soft stuff. And in Rochester, New York, Mary Dombeck, it was their nursing program, writes about professional personhood. And this isn't about individual people. It isn't about an individual person. Professional personhood refers to the web of roles and relationships that are required and enacted in a professional setting. And professional education is more clearly a process of socialization than other kinds of adult education, because it requires not only levels of knowledge where you're learning everything that you're learning about your discipline, but when you go into a clinical room, that you're actually perceiving codes of behavior, the way people talk to each other and work. What is the role of a physician or the role of a nurse or of a pharmacist? And what's interesting is that all this stuff like biochemistry is very explicit about what I needed to know. And yet, learnings about personhood, about how you behave as a professional, were transmitted implicitly by being in the culture through the actions that we receive, the rituals of socialization and initiation. So what do we know? How well does that work? So we can look to the professionalism literature now. And in medicine, we said, professionalism it doesn't have to be complicated. It's a set of values, attitudes, and behaviors that results in serving the interests of patients and society above my own interests. That I will put their welfare first. Right? That shouldn't be too hard to learn. I'm sure every student in our audience would agree that that's something we should do. So what gets in our way? A group of residents published a paper about why learning professionalism is so difficult. And they say, the literature misses the mark. And yeah, it's nice to have ethics courses and other things, but that's not where we learn professionalism. We learn it in the real world by watching the way our mentors behave and talk to each other and treat each other. And specifically, they said the chief barrier to medical professionalism education is unprofessional conduct by a medical educator. And it's not only tolerated, it's protected by a hierarchy. Gee, he or she's a very important surgeon. They bring a lot of money in here. It's okay if they abuse a few people in the operating room. No, it isn't. No, it isn't. That's toxic to what we do. And then they tell us that, it's interesting because as you evaluate us professionals, and we see this unprofessional behavior in a practice setting, it invites us to not understand what professionalism is, to have conflict, to have compromise. It's okay, you don't have to do that all the time, because that's what we see people doing. And the interesting thing is they said, gee, we would naturally be attracted to behaving the right way. But I guess that doesn't work here. That really isn't the code of behavior in our environment. And so I'd like to shift to an educational perspective and cite the work of Fred Hafferty, who's a medical sociologist. Fred gave us the hidden curriculum. So what is that? So you have the formal curriculum, it tells you what you have to learn, biochemistry. Then you have the informal curriculum, and that can be good or bad. It's whenever maybe some teacher will go the extra mile and really inspire you. And gee, it's not in the objectives, but boy, what a wonderful role model. Or someone might make a joke about a certain you talk about mutual respect and diversity, which we don't really live it. So it can be positive or negative. The hidden curriculum is that stuff like, gee, you're not going to let that nurse tell you what to do, are you? Hey, that's our area. We're the ones that oversee this. It's the conversations that occur in cafeterias and parking lots. It's the conversations that occur very informally, and yet we're transmitting values and beliefs and codes of behavior and understanding. And so Fred says the first step to working purposefully, and he's written for medical schools, the first step to working purposefully within curriculum is to conceptualize what we do as a culture. That medical school is an important player in the transmission of that culture, and that medical education itself is a process of culturating. And when we talk about things that are vague, like the IPEC things, values, teamwork, communication, integrity, altruism, trustworthiness, it's really the hidden curriculum that tells people what that means, not the ethics class. It's our enacted values, not our espoused values. And the hidden curriculum, again, can be neutral. It can be extremely positive, and it can be negative. And so what is a way that we might take a look at ways that we can succeed? I think you were all given an article, and I'm going to go into a line of work that I think is very interesting for us and has a lot of promise. The reason that we're interdependent on each other, the reason that medicine is a team sport, is that we have to perform tasks, and we need each other to perform those tasks. That's task interdependency. And there is a theory called relational coordination, and it says that coordination of work is management of those interdependencies of the tasks that we have to do. And the way that we manage it is to manage the relationships of the people who come together to do that work. And this is the work of Jodi Ofer Patel, who's at Brandeis University. She wrote a book. First book was Southwest Way. Every other airline is going bankrupt. Southwest is growing, turning in record profits. Why? Her answer was the way they work together. She's written a subsequent book called High Performance Healthcare, which is a very easy read, and it applies the theory of relational coordination. So what is it that she says? And I'm going to boil this down. You have this. And so Jodi says it comes down to really four things. Shared goals. So we all understand what the plan of care is for a particular patient. Shared understandings. We all know what we need to do together to accomplish that goal. Mutual respect. And this isn't fluff, this is key. So the way it plays out is that I have to believe that anybody that I work with cares at least as much as I do about getting it right. And when something goes wrong, it's not who dropped the ball, where's the blame, it's I know you guys, I know what happened. We all care so deeply. What is it that we need to learn to prevent this from happening again? Because things are going to misfire. Mistakes are going to happen. But if we get really good at creating a learning culture, not a performance culture, then we'll seize those opportunities to learn. And then the other element, in addition to shared goals, shared knowledge and understandings, mutual respect, is effective communication. And effective communication is frequent, timely, accurate, and of a problem-solving nature. Here is what you need to know from me in order for you to succeed at your I receive the same kind of communication. So, now, has this been played out in other areas? The answer is yes, and there are different theories that describe this a little bit differently. So one of the companies that had fame and has been studied extensively is the Toyota production system. And they have, they've designed their work so well that if I were the person putting the doors on, and I needed so many bolts, let's say 8 bolts to put a door on, I would have to keep track of how many bolts on. And so when I get low, I would call the supply room and say, set some bolts. But the supply room keeps a record too. And if I get distracted and I don't call, the supply room calls me and says, hey, you should be running low on bolts. Do we need to send you some? And the answer is, wow, yes. I got distracted. So it's about the work. It's the designing systems where the work succeeds. And so at Toyota, every worker understands the next work, any worker that they could possibly be connected to, they understand what that person has to do and what they need to succeed. And when they talk about communicating and understanding, they refer to the communication as customer-supplier in nature. I know what you need from me, and I supply it. But then Toyota does something else. They eat lunch together. They have games together. Their teams are people that know each other, and despite whatever differences they have, they begin to care about each other. And in addition to understanding what they need from each other, the relationship that they have is, we don't let each other down. That's the last thing we want to do, is not be a good team. Okay, so now I'm going to briefly tell you about Mayo, which I think, to me, it's been a real blessing in my life, and I'm going to tell you about our culture, because I think it's very important. And then we're going to close with a little discussion about experience and what works. So William Worrell Mayo was the father. He was from Salford, England. He studied with John Dalton, who was the father of atomic theory. So he was a very disciplined student. He came to the States. He trained in both Michigan and Missouri as an apprentice. And he became a very skilled surgeon. He was a horse and buggy doctor. And so he would travel into the countryside and he would do operations on kitchen tables. He got good outcomes, and part of the reason was that he washed his surgical instruments before the operation, something that he learned from John Dalton, that there might be a few bugs around. In the Civil War, President Lincoln asked William Worrell Mayo to move to Rochester, Minnesota, because Rochester was a north, south, east, west wagon crossing. And he asked him to go to this vibrant Midwest little town to induct people into the Union Army. And so he came, and he liked it. He set up shop there. And he did his horse and buggy medicine in the country. He had 2 sons. From the age of 6, he took them along whenever he did operations. They assisted in surgery from the age of 6. Later, Will, who went to the University of Michigan, said, boy, we came up in medicine like farm boys come up on a farm. We learned everything by doing it. And they compared the education they had observing their father compared to the university-based education, and just said that they had learned so much in that way. So Charlie decided to go to Chicago Medical School, which is now Northwestern, because he didn't want to go to the same school. He wanted to have a different perspective about medicine. They understood that they might learn things a little bit differently. Will graduated in 1883, which was really an interesting year because a tornado hit Rochester, Minnesota. 37 people were killed. Lots were injured, and they had nowhere to go. And so the Sisters of St. Francis, who were in a teaching order, Rochester had a central school, was that vibrant, wagon-trained community. This teaching order took people into the convent and nursed them. And then after it was over, Mother Alfred Lowe's went to the father of William Worrell Mayo and said, we need a hospital. And he thought she was nuts. He said, sister, only big cities have hospitals. Rochester can't sustain a hospital. She wouldn't take no, so she pinned him down and said, if we build a hospital, will you be our God? And so he thought, geez, I don't have to worry about that one. And so he said yes. They raised the money in 2 years, and they opened St. Mary's Hospital, which was the beginning of the Mayo Clinic, in 4 years, in 1889. And the rest is really history. But just to show you this picture, and I think I have a quote. So this woman is, so here you have Dr. Will operating. Here, this is Alice McGaugh, who's a nurse. She became the most skilled ether anesthetist. She wrote papers about it. She wrote papers about talking people into, and got the best outcomes of anyone ever. And I think you can see Sister Joseph Dempsey, who was Dr. Will's surgical assistant. She had small hands, and often when things were in crevices, he would ask her to do, she would continue the operation. And so today when we talk about teams, we talk about trust, and we talk about, look at, they didn't talk about it. This is what they did. And so Edgar Schein is an expert in culture. He tells us that culture, really the essence of it, is these basic assumptions, these unconscious, taken for granted beliefs that guide our perceptions, they guide our thought and our behavior, and they serve as the ultimate source of group values. This is the way we do things. Argers and Schoen said that these basic assumptions are theories in use. They define our perceptions and our reality, and they determine the actions we take in various situations. When you see a high-performing organization, one of the characteristics is everybody understands how they can give that extra discretionary effort, go the extra mile to do whatever it takes, because that's what we do. And so the diligent emphasis of patient-centered, Mayo, the needs of the patient come first. That's what we always say. That's our equalizer. And it gives us a focal point to work collaboratively, where we can align our behaviors, our activities, and our resources to accomplish the mission that we have, which is to provide the best care for every patient every day. And this constant focus gives us both a moral compass, that decision-making, and a yardstick. How did we do? Who did we let down today? What could we have done better? And in itself, a culture like this is one of the most powerful, positive hidden curriculums that we have. And if you ask people who have trained there, they will tell you they learn so much by being immersed in a place where this was the understanding of what it is that we do. So I'm going to close by talking about experience, because there's a lot of experience is the best teacher. Well, sometimes. Experience alone, not necessarily if people keep doing the wrong things. But experience with formative corrective feedback, it's called deliberative practice, is the best teacher. And deliberate practice is Anders Ericsson's theory that mastery takes 10,000 hours. But specifically, whenever you're working as a student in a healthcare setting, the task should be very well defined for you. It should be the appropriate level of difficulty. You should be given feedback about what you do well and what you need to work on. There should be an opportunity for you to do it repetitively. And if you aren't doing something as well as you should, there should be opportunities for you to correct what you're doing. And we know from the Interprofessional Education Collaborative that the best clinical education is active and experience-based. It occurs in teams that know how to collaborate, The most important thing in my mind, whenever we're working with a student, is really let them be the agent for the patient. Let the patient thank them. Connect that student to the meaning that comes from what we do. That's the best motivator in the world. We should be coaches, not knowledge experts. Hey, here's what to do. And there should be a lot of reflection at the end of the day. How did we do today? Do you have any questions or what, but it's open dialogue. And so to succeed moving forward, the issues and problems that confront our healthcare system are so complex that we need all hands on deck if we're going to succeed at this. We have to work together. This is no longer optional. And we know and we believe that the best education will occur in the settings where the best practice is occurring. They will learn by doing. So the best achievable patient care is the best clinical environment. And learning by observing and imitating experts in culture it's that powerful social learning mechanism which largely has been missing in the past from what it is that we do. And if you think this is a new concept, Aristotle believed that we learn by practice, and the best practice is to follow a truly virtuous person who is doing that. So I'll close by saying that really we're all in this together. And faculties, we are faculty in an apprenticeship system. And we have to be everything that we want our students to become. Thank you.